Welcome, David. Yeah, welcome to our channel, our podcast, and pleasure to have you.
Thank you for having me. It's an honor.
Okay, so just for our audience, I would let you introduce yourself. Take your time. We will love to hear about yourself.
Sure. Yep, my name's David Mullin. I'm currently the director of medical economics at a branch of Optum. Currently working under the Florida region, under the South region of their uh, Optum Care, which runs general practice for the Medicare Advantage market. And over the past 10 years, done a lot. It's been technology throughout COVID and with data science and the advent of AI and analytics. It's been quite a whirlwind. And a lot of the companies in this area, and especially in healthcare, they were kind of in a way, the last industry to be advanced in the US. It started with manufacturing, and then you saw it in the finance industry. While much of the healthcare world was still running on paper and fax and using Excel as databases. The company that I started with here now 3-4 acquisitions ago, they were using a technology called Fox Pro. So for anybody that may not be familiar with that, it's a pre-Microsoft Access type of SQL / object-oriented programming reporting that they stopped supporting well after the company continued to use it.
I worked
and
on it.
yeah, and so it's like yeah, and so part of that was kind of bringing them into current, giving them good tools to do all the things that you know in short healthcare companies would like to do, and that's kind of what I've been working on.
Yeah, perfect. Actually, health sector is something which I was finding someone, searching someone who can really talk about health
Mm,
because in data world like our world, uh, mostly we give importance to stock exchange, banking, especially sector, financial sector.
mm,
But for me, one of the most, and as you correctly mentioned, I think healthcare is one of those domains which were on the manual stuff till the last moment, till the time this COVID comes in, right? That is
right.
when they had to get digitalized, right? And this is one of the most critical domain, I would say, which really need attention when you are digitalizing it, right? Because you
Really.
can't make a mistake, right? Your lives are dependent on whatever you do, right?
Yeah, absolutely. And it's it's difficult to kind of think of that in the context when you're on the data side a lot of times, but technology is embedded in anything that does affect the people's real lives and their health, and that cascades into their families and their communities. We have a statement that says all healthcare is local, and it's not having these things that are efficient, that are out there improving people's lives to make people better. It creates kind of abrasion in people's daily lives, right? Because every day is a bit of our health, how we eat, how we sleep, how we exercise, and those that we love and care for, is something that's front and center every day. And just it's a pleasure to have an impact on that.
Yeah, like we always say, right? As far as data science is concerned, AI is concerned, the financial sector is one of those they say, hey, we really need results up to 98% or 99%. But when it comes to health, I think it's 100% you need a proper result.
Hmm.
You cannot just let it go. Okay, let's 1% go. Let machine make a mistake, no problem. There is no rollback, right?
Right.
Industry, right? So yeah. So this is a domain which is hardly touched by many people.
Hmm.
And I'm really happy that I found someone whose name is David. who is working on data as well as in a health industry. So I have my few questions with me traditionally, just like I have it. So I think my first question is the question which everybody is looking like. What are the key areas where data can make real difference or impact in health industry? I think this is a basic question. We start from here. Yeah.
Right. Um, I think most of what I've seen recently is really around enhancing literacy, right? And so you have all these things that are very complex in medicine. You have doctors with medical knowledge, you have the administrators with administrative knowledge, you have the technology teams, which do not receive that same education. And then on the flip side, I think if you asked most clinicians who went to med school or nursing school or whatever,
Mm.
if they never had to sign into a system, they'd be very happy because at the end of the day, they
Mm.
just want to spend time with patients. And
Yeah.
so data does a good job of trying to bridge that gap and kind of communicate to people where care affects dollars, dollars affects care, and to give people the education so that they can basically make decisions for themselves. And you can do that in lots of ways.
Yeah, so actually I was discussing let me bring this technology as well. Nowadays Gen AI is the buzzword nowadays, right? And everybody is trying to implement Gen AI everywhere.
Right.
And that is where I've heard like people are creating use cases on health industry using Gen AI, which
Hmm.
is for me is a very, very risky thing to do. But of
Right.
course we have to grow, we have to go to the next stage, we can't let it go. But the thing is, once we go, as I mentioned, that health industry is a very, very, I would say, risky industry, and you have to be very careful, right? Now,
Hmm.
as you mentioned, literacy, right? Most of the, I would say, 99% of the world health industry are from those countries. If we talk about the numbers of patients and doctors, right, are from third world countries or developing countries, not a really, really developed countries, right? Even in developed countries, the integration, how do you see the integration of clinics, hospitals, gadgets, and patients bringing all data at one place and then take a decision? How do you see this whole ecosystem joining together? Because if you don't have all the endpoints, of course, you can't make a decision, right?
Right. In the US, it's particularly difficult too because it's a very segregated system. We have a lot of lack of communication because we don't have a centralized, socialized medicine in really any way, shape, or form. We have for our elderly population, we have Medicare, and that is able to consolidate a lot of information around the elderly. And although Medicare does have individuals who are younger, but it's mostly the elderly. But then when you get into like commercial plans and like Medicaid, it's all very kind of state and industry and it's hard to get one source of an individual's medical record, right?
Hmm.
We see a lot of individuals trying to create in the similar way that research organizations do. They will create joint ventures essentially for data to where they can share de-identified data to start building on a lot of these models. They also in the US, they have the Milliman clinical guidelines, which I believe 80% of organizations use. Um, it's an actuarial organization which is kind of at the forefront of 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 healthcare for many years now in terms of working with insurance companies and payers to try to project outcomes and how benefits affect care and the financials, and that's what a lot of organizations do. And so if you could somehow kind of combine those two for the success of those clinical guidelines. It's a pretty, I wouldn't say it's a like a boilerplate process, but I mean the way the Milliman coding works is the or clinical guidelines work. It says, if you have this, these are the conditions under which you would need to have a referral, or maybe go to home health, or maybe go to a referral for some any number of specialties, right? And you can go through each of various circumstances that kind of show, what the latest clinical research is showing that we should do, right? Um, but it's fairly intensive to kind of update all of those things. And Milliman has the benefit of being a very large organization, like a Facebook or an AI that can kind of combine a lot of this information in a way. But what does everybody else do?
Hmm.
um, who is trying to do something more prescriptive, right? And I think those ventures are a good way to go. I think and a lot of what generative AI does in terms of trying to create, um, synthetic data, so that if you're working off of a small population of members using, maybe industry statistics, or using comparable populations without necessarily digging into like HIPAA protected data, is creating data around those populations, start building up your models to kind of make the care more prescriptive.
Hmm.
Most of the medicine in the U.S., or I should say, the cost is in the top 1 to 20% of individuals. It's a very small pool. It's very specific diseases, and we're just kind of tackling them one at a time.
Okay, so I think you brought up the relevant content for my next question, where you are saying how healthcare industry addresses concerns related to data privacy and security,
Mhm.
especially under the light of HIPAA, HIPAA, right? So
Right.
when this data you bring in, right, that security and privacy come into picture, as you mentioned, that synthetic data, can I take it like that in health industry, we really, really need synthetic data because you do not know where the data is coming from, and putting up privacy rules and regulations inside the code is a little bit difficult.
It is difficult because it depends on what a lot of people are trying to do. So, like, if you're, say, where a lot of AI is going right now, which is in trying to create, patentable software products, there are a lot of rules around your ability to do that when the data isn't yours, right? And the effectiveness of those algorithms to prevent the progression of healthcare throughout the organization, or through patents, right? So, patent lasts like 20 years. And if you find a method of, say, improving some measure of diet for diabetes patients, or some measure for Alzheimer's patients, um, you, there are rules around not only the data that flows into it, but also rules around your ability to prevent bettering people's lives, right?
Right.
For the sake of a patent, right? And then you've got those aspects of that are where it's a little bit more prescriptive, where you're trying to take, okay, so this is what the industry does population health wise, but there is a level where all healthcare is local, and there will be, as we know in statistics, anomalies when you actually jump down into the sample, right? So,
Hmm.
like, how somebody, you may see like an overall clinical guideline or a plan, but it might affect people in California differently than it affects people in Florida for any number of reasons. I mean, the big example that I always give is, uh, Oklahoma doesn't have red tide, you know. Um, Florida is warm, which the humidity and the heat will present different rules and circumstances for those who live in consistently cold climates, right? If you have, say, certain immune disorders or respiratory diseases, right? And
Hmm.
so it is very local. And the ability to kind of make that information prescriptive, those anomalies, although in a population health perspective, may be improving the overall population, at the end of the day, you can't get past knowing that individual's personal circumstances when trying to provide that care. And as much as you try to advance those models and advance their accuracy, um, what goes into those models becomes kind of like a black box. And the biggest confusion that I see with a lot of these tools is because they'll get like a number or a metric or a guideline, But the doctors that are probably the most hesitant are the ones that say, well, what was the criteria that you even decided XYZ, right? What did you see from this patient that I may not have seen that drove this? Because maybe because of our segregated market, I'm not seeing it. Like they need to see it in a real health record, right? And that's kind of like the two spectrums, I feel like.
Yeah, so I was good you have raised it, right? Like patients sitting in one part of the country and sitting into another part of the country having same symptoms does not mean they have the same environmental effect onto it. So there's a lot of parameters in every
Mhm.
different region which impact the patient's health. So that is where I was thinking that it might maybe you're the right person to answer that as well, that in health industry we cannot have a centralized decision support system. It has to be federated. It has to be based on the geolocation of those patients where they are. And it's not only geolocation, I would say what's happening over there. Is it a region where sports are very into it? Is it a region who doesn't play sports? Is it a region who is near to sea water? Is it a region which is top onto the mountain? All these factors, I think, impacts the patient's health. Correct me if I'm wrong.
Absolutely. And I just want to add a third one just because I think it's terribly important, which is uh metropolitan areas are well served in most areas, right? But once you start getting out into rural areas, how far someone might have to drive for their healthcare could go from 5 miles to 50 miles.
Hmm.
Or in some places, we're seeing, especially in very rural areas, they're calling them essentially medical deserts. Like you have food deserts
Hmm.
where, depending on the specialty, you might have to drive 50 to 100 miles to
Hmm.
find care. And to some degree, people are taking care in their own hands, right?
Hmm.
Um, and so when it comes to that aspect, they call that somewhat rigidly patient compliance, right? The individual's ability, either through resources or understanding, to actually follow the advice they're being given by a medical professional through various means. And yeah, it's all local.
And there's a different style of doctors as well, right? Some
Mhm.
depend on very, what do you call it, heavy doses, antibiotics. Few goes for a traditional way, right? So different
Right.
patterns of doctors as well, right?
Yeah, it's tailored to who's kind of up with and willing to work with more recent methods, right? Um, Cancer is probably the one where you hear about a lot of the advancements, right?
Hmm.
Um, uh, Ozempic is the popular one in the US that's in the news around
Hmm.
using it for diabetes or obesity or both. Um, I think, and there are different manners of providing care that would be more willing to provide new methods over, methods that have been practiced and proven out for say 10, 20 years, the ones that have always worked for them, right? They're very hesitant to change a therapy for a patient if the one that they've been given is working, right? That's the hardest thing. Yeah. And so it's going to be a practice where you have constant research, constant change, and AI is going to be a part of that. I think that's one of the benefits I think that I'm very hopeful of, is that you get to see research and the outcomes and insights to be more rapid, because that data can be collected and analyzed more quickly.
Correct, actually. So that is where I was coming, right? First, we have a challenge of integrating his hospitals, clinics, especially gadgets as well, that you have to bring data at one place. Second is you need to ask doctors or whoever who is writing the prescriptions to digitize that. And then that is this machine learning or GenAI comes in. And I always am a believer of domain specific taxonomies and ontologies, right? You have to be very specific that what industry you are talking about, especially in medical, and then we go back which region you are talking about. So the
Right,
taxonomy, the ontologies need to be based on local, as you mentioned, right? It has
right.
to coming there. So now coming back to our data world, right? What do you think this data has played? How much impact has created, or what is the trend between last decade and this decade? Because it's very important, right? Because in last decade, COVID was not here. Now COVID was here. What
Right.
is the impact? How do you see this whole change?
Well, when I first started in this, I would say circa 2014, maybe, um, at least in my local region, I was kind of new to this idea of uh, analysis existing outside of the standard vendors like Cerner and Epic EMRs or um, Oracle and there's a lot of other different types of EMRs, but I think those are the ones that people might be more familiar with. ECW is another very popular one. Allscripts is another popular one. Um, but then there was also like ERPs for the much larger organizations. They would have, Oracle and SAP. But then they didn't really have a title for those individuals. They all existed under the IT department. They
Hmm.
weren't as business facing. They were focused around building software and supporting software and maintenance. And I was just fortunate to come up on the upswing of when a lot of people in our area were starting something called medical economics, and then somewhere between that and what some individuals in the industry might be calling uh, healthcare economics, which is essentially the same thing, you saw analytics and data science really kind of explode, and you had all of these individuals who were applying software development mentalities
Hmm.
into kind of speedier ad hoc analysis and tools. And through that, you got Tableau. You started seeing individuals who were just not using SQL and C Sharp to uh, build software. You were seeing it to build on the spot, done in a week or two type of reporting to bring more more of this data to the customer in a customer service way. It wasn't where it was just like you had development, quality, UAT, production. They would jump in, and then all of the development and the QA were really separated. Right now, what we do in analytics, and I'm probably preaching to the choir here, but this is me and my brain in 2018 seeing this all come alive, where I'm in front of a doctor or nurse or a case manager, and they're asking me questions, and I'm mining the data and querying the data live and giving them answers live and building out my requirements of what the eventual thing I will deliver in, say, the next 2, 3 days a week, but not in month-long project sprints, right? I mean, in like quickly. And that was really fascinating. And so now we're seeing the advent of tools that run really, really fast. And you're seeing a lot of cross-functional application be done really, really fast. And people are getting very, very good at using reporting tools and BI and SQL queries who are focused on the business and not just on software development. And it's been really fun.
Okay. So what do you think? What are your thoughts about, because health industry is a huge industry, right?
Right.
What are the low-hanging use cases you think that generative AI or machine learning or AI can really hit and create benefits for patients as well as health industry?
I think it's really going to differ by specialty, right? What might be low hanging fruit for, say, a general practice, practitioner is going to be, I would say, maybe hospitals have a higher priorities, right?
Mhm.
Um, when I talk about general practice and family practice, you also have this idea in the U.S. where it's coming around. They have ACOs and value-based care models where you are essentially financially responsible for the entire care of that patient, opposed to historical methods and fee for service where you're only providing a service at that point in time, right? And so you have all these kind of disparate reimbursement models and kind of differing complexity in all these different providers that are all going to have different priorities, right? Um, in my genre of full risk Medicare Advantage, we are responsible for the entirety of the member's care. But we don't have oncologists really. We don't have nephrologists really. It's mainly just family practitioners managing the care of the patient and being kind of the person that keeps tabs on them from every handoff, right? And is given that information to be able to provide that type of knowledge and benefit to the patient. And so that's where I see the low hanging fruit for us. It's low hanging in the sake that if someone figures it out, it would be so successful because it's such a key item throughout the process of how our genre of medicine provides care. And that includes some things that I've worked on in the past where, um, you're creating like bag of words analysis on clinical notes to try to project what might happen to that member 2 to 3 months from now. Um, where you are looking at and analyzing their benefits against their history of care to try to help them decide like these are the things that we would expect to happen to you in the next 2 or 3 years so that they can then go to their broker agents and make better decisions and also and if we can get those systems together where we are providing more knowledge to the patient. Um, I can't say that we need to have customer facing AI. Like I don't think it's there yet. Like because in healthcare, if you tell somebody the wrong milligrams to use in their medications, or you tell them one pills instead of two, that's the difference between life and death. So I don't think
Yeah.
AI is quite there yet.
Yeah.
But I think there are aspects of AI where we've seen where it's looking at a patient's history, it's providing some sort of uh, face sheet of education, right? That a doctor can then go to review without a nurse having to go and then compile all those notes from the various sources, right? And it's doing it with real language, not ones and zeros. That that if I and people like me do our job right, puts it into the language that medical practitioners use every day, which is huge, right? Because there's always kind of this lag between trying to understand the cross-functional nature of healthcare, right? It's like there always need to be some sort of translator or liaison in there, or somebody that's used to talking in both worlds. And to some degree, the technology can do that for us.
Yeah, I was coming towards the VR actually. That because this
VR,
yeah,
ooh, yeah.
yeah, right. This is something which I am very much excited about, right? And
Mhm.
will this open doors for a lot of doctors which are sitting very far in urban areas and rural areas cannot come together nearby? I'm not talking about robotics where you can do in surgery, you put your hand inside and you do the surgery. That's very
Right.
sophisticated, right? I'm talking about very basic VR things that patient is sitting at home, doctors are somewhere and connected with the system and then suggesting because see most of the if you do percentage most of the I don't know what is the percentage these the minor diseases small headache cough these are have more numbers as compared to bigger diseases, right? And
Hmm.
these ones, patient don't need to go to a clinic. They can stay at home and get it checked by the doctor. What do you think about that?
I think it saves people some time. We have recognized some abrasion, and I think it's mainly a generational driver. But we have recognized some abrasion where people sometimes do want to see their doctor in person.
Yeah.
It's they, And we see this in the return to office discussion too.
Yeah.
Some people just have to see a face, and they have to um, have that in-person connection, right?
Yeah.
And especially in like the Medicare Advantage space, to where you are responsible for so many points of that person's care in comparison to like fee for service, they you begin to form kind of a relationship in a way. But I think for those patients that have issues with driving or
Yeah, especially
or
rural area, right? As you mentioned, people have to go to 100 kilometers on
yeah,
those regions. That is where these things will really help.
right. And people that have trouble getting off work, who are working hourly jobs that frankly, you have to take an entire day off from your employment, opposed to just maybe going to your car during one of your breaks and speaking to your doctor about some chest pain or cough or whatever. And the biggest barrier there, I think, would be solved with VR, right? Because part of it is you can explain what's going on, um, but anything where you're looking for like signs of like swelling or discoloration or and so forth, sometimes the patient's device is not great, right?
Mm.
On their phone, right? Even if they have a device. And I think there are groups out there that are starting to invest in technologies of providing it. They say, if um, if you want to be a part of XYZ program, they'll give you an in-home device, right? And they're selecting key people who would get the most use out of it, and giving them the technology. Right now, it's like tablets, but yeah, at some point it could be something a little bit more high tech, where it's just not tablet to tablet conversation, and yeah, it could save people a lot of time and a lot of headache. And I think they would appreciate the doctors and the patients alike would the kind of the more rapid response, right? It's not like I talk to the desk. When am I going to talk to the doctor? Oh, come in 3 days from now. It's more of like it's a little bit more efficient for the patient. Can't say it necessarily saves any time for the doctor because they're not the one doing the driving and the traveling. And so there is some of a training aspect of getting uh, clinicians comfortable with the kind of the flow of it, right? There's a few
Yeah.
more clicks, there's a few more environments that you got to get into, there's a few more devices you have to go to.
Yeah.
Do those devices integrate with your EMR? So if you do have to kind of build that, what's the process to make sure that that gets into the record, or gets into the medical record at all for that matter? Um, and yeah, anytime you take the process outside of the system, someone has to then go in and enter it in the system, right? So there's some of that manual intervention on the clinical side of getting that notes and that experience into the EMR, into the EHR. And yeah, but no, I think we're seeing that to a degree. Absolutely.
So on this point where you say someone has to do it, for me, that is where audio and video will really grow. That's what I feel.
Yeah.
That if every doctor and a patient has a video or have a mic there, and you are able to convert that, because you can have you can when patient is talking or a doctor is talking, you can take those vibes as well, right? That
Right.
is where unstructured data will become really, really a key area for me if I talk about especially health industry, right? Because you
Yeah.
don't have, even in banking sector, right? You have people, they are working on their laptops day in and out, so they know how to handle technology, but not in medical industry. They are doctors, they are patients. Both key key area is not using computers other than using mobile, right? So that is where
Right.
for me audio and video data coming out of these two channels or medium will become very important for converting. So now coming towards technologies, Which technologies do you see in current era, which is really getting popular, or which is who are really doing a good job to integrate data and doing some real work?
Well, I think kind of the more of the big box off the shelf vendors are starting to see the benefit. Even in like 2018, 2019, even things like data science and analytics were a little fringe. Yeah, and when you had, say, like a chief informatics officer, um, I can't say in my experience it was consistent that they were promoting analytical analysis or data science or anything like that. They were more trying to advance existing EMR features,
Hmm.
which are the same features that have been around for 20 years, right? More or less.
Hmm.
But now, we saw, what was it, maybe a month ago, where Epic, one of the largest EHR vendors in the entire US, is now starting to institute AI into their tools so that they can get people the data that's already existing and um, you know, use their cache of data to kind of do something like the Milliman clinical guidelines, but something to where the prescriptive results, pop up in the EHR at the point of care, where a lot of the analytics, before has been kind of you'd have to take it out of EMR, you'd have to take it out of the system, you'd have to take it out of that system, you'd have to build pipelines, and and trying to do more in the EHR itself. Um, there are other products out there like we have an organization just down the street from us called Zealous. They're based out of Boston. Um, they kind of focus on network management and how you scrape and pull and organize providers across the US so that you have not only for identifying providers that might be high quality for your network,
Hmm.
um, but also helping to kind of organize the various terms of reimbursement across those providers for your organization. Um, I think that those have been the two that I've kind of had on my mind as of late. And then there's all kinds of other like population health. I mean, population health is the idea of it has been around forever. And I think it's been such a low hanging fruit for such a long time. There are so many good vendors out there. Um, one that comes to mind is Cativity. Another one that comes to mind is Lightbeam. There are all kinds of applications out there that if you're doing like on any of the kind of the ACO ventures that specifically design their applications just for ACO ventures. Um, and yeah, that's just kind of in my recent experience, but the landscape is constantly changing.
Yeah,
Um,
yeah. So
and I think a lot of these big box off the shelf type of organizations are kind of ready to dip their toe in, but in a way that is finally, they're finally willing to release it to customers, where before it's been kind of, individual actors, smaller actors trying to make impacts on small cap and middle market uh, practices. So yeah,
correct, correct. See, that brings me to my next one, right? As you mentioned, there are so many vendors now because of this COVID thing. IT industry has really, or AI industry has really started looking into health industry as well, right? And so many vendors are coming in. So can
yeah,
I say that, like, if you go back 10 years or 15 years back, telcos and banking, these used to have only IT small teams which used to manage their OLTP applications, SAP and XYZ. They never have analytical teams. But now you can see in every telco, every bank, they have their own floors, own buildings where they have in-house data teams, analytical
Mhm.
teams. They have CDOs. Well, we know that CDO role is one of the most moving role right now. They are still not successful, but they are focusing on that.
Yeah.
Can we say that that time has come that health industry, hospital level, or those levels should also focus building or bringing CDOs in their industry, in their organizations, where CDOs will take, no, I won't say take a decision, will be responsible to bring multiple data. Yeah.
That are tied closely to the value of organization, not just like a back office corporate function,
Mm,
right?
mm, mm.
Um, and a lot of the banks have the benefit of scale, right?
Mm.
So if they do focus on data, they have the scale to be able to hire in 20, 30, 40 people to just focus on that. Um,
Or not only internal, they can bring the vendor as well. What I'm
mhm,
trying to say is focus on data much more as compared to previous decade. Yeah, vendors can
yeah,
come in, no problem. All those companies can come in and they can build. But right now, health industry organizations, which are hospitals, they don't have focus on data. They come
right.
up, do a out of the box solution. Do you think it's a time they should start focusing on this piece as well?
I do kind of, and maybe it's a little bit selfish in a way, but I've found where a lot of the gap is in understanding what data you have, right?
Yeah.
I forget what the phrase they had that came about not long ago. Well, actually, might be quite a few years ago, where it's like ghost data or like black data, right? So you have all this data sitting on FTPs. Only you're
Dark
really
data.
where
Is it dark
what was
data?
it called?
Dark
Dark
data?
data. Thank you. Yeah, dark data. Where you have all of these sources sitting away from the users. They don't even know what you have.
Yes.
And they don't have anybody to really kind of connect with them on business purpose. So when they're going through and
Correct.
asking for requirements, after it goes to the chain of three or four or five different people on the application development team, it kind of loses what you're trying to do, right?
Hmm.
And to have people in your organization that are mission ready
Hmm.
on what data is in your organization, what you're using, what you're not using. Is it cataloged? Are the pipelines sufficient for the users? Um, are we instilling best practices, right? Because now a lot of the data is not coming from is not generated in house, right? That's something that's I found is very unique to coming into the industry that I'm in now, opposed to my prior lives, right? In my prior lives, all the 99% of the data was created in house.
Hmm.
Now, 99% of the data that we use to run our business is not created in house.
Yes.
It's unstructured, unconformed. We have to figure out how to transform it into something useful. Comes in PDFs, in text files, in audio files, and image files, and files we receive from third parties where there's no SLA involved, right? Because we're just pulling industry information that we now have to kind of integrate into the process, right? And yeah, I don't know who else would be interested in doing that, to be honest, because it's its own job, it's its own understanding, it's its own domain within the field to be able to do that. Yeah, and that's honestly why I'm here in a way, and why I'm kind of close to it because prior to, yeah, we didn't really have a process to combine all the information to where you're integrating unstructured data, proprietary applications, third party structured and unstructured data
Yeah.
into one solution. Yeah, we didn't have it
So
before.
normally in my sessions, we really go towards data vault, data lake, mesh. I normally talk about that, but I did not do that in that session because, correct me if I'm wrong, in health industry is still at the edge of the start, where first they have to integrate, right? Integration is, I think, health industry is still not there that all kind of endpoint data can come at one place. When it
Mhm.
come at one place, then Lakehouse, Data Mesh, Data Lake, all those will come into picture. What do you think with your experience? How do you see this data industry inside the healthcare or health industry?
Mm.
Are they really going very fast? Because since Gen AI comes in, right? So Gen AI actually has put data science as a backend, although Gen AI is data science word.
Yeah.
But since Gen AI has come, nobody cares about data science anymore, right? That buzzword right now, buzzword is Gen AI, right? Although it's a data science, but it's a buzzword, right? Now things are moving so fast. What is the healthcare industry or health industry speed to catch up with these things?
Yeah. You kind of see it in two groups. You have your small and middle markets, which are looking for those vendors that really provide one-on-one customer support. You find
Hmm.
out a lot of these individuals when they work in these applications or in these regions, once one person likes that application, they tell it to the next doc and they tell it to the next doc, and it kind of moves on. And you have kind of, but it needs to be a little bit more personal when you get to
Hmm.
that. And then you kind of have kind of the large cap and above, they're trying to do a lot on their own, in all honesty. And that you're seeing a lot of kind of like vendor consolidation,
Hmm.
especially right now because they're talking about, recession in the US and they're talking about a lot of different things. I think it's just the natural progression of consolidation, of industry consolidation anyway, is vendor
Yeah.
consolidation and that ultimate decision of buy or build. When it comes to the large organizations, they're running a little slow, and that's because they're struggling with not having all the data in one place and all of the insurance companies not having a consistent platform. There's no national industry standard. Like everybody who submits claims to Medicare has to do it in a consistent format. But once that biller or payer has their way with it, it doesn't come back to us in the same way. And there's no industry standard to
Yeah,
force
yeah,
them to do it
yeah, yeah, yeah.
because they're running their company, they're running their organization in a way that makes them profitable, and it becomes this negotiation for around the completeness and the quality of data. And it's very difficult, right? If all your data is not created in house, and so you're seeing them tackle whatever the low hanging or what the industry wide uh, kind of standard processes are, because at least that'll scale, right? If you
Hmm.
have something that is really being done anywhere, and there's a greater opportunity for to put a lot of money into it, right?
Hmm.
And right now a lot of the generative AI type of work development is a little bit expensive, compared to because they're experimenting with it, right? They don't always
Yeah.
know what to do, right?
Yeah, yeah, yeah.
And so you have in our industry, it's pretty standard, right? You've got risk adjustment, you've got HEDIS, you've got your standard industry calculations, like in measuring utilization, um, and you kind of start with those industry standard benchmarks, right? And then once you kind of break it down into the regional level, um, we're not really there yet. We're still kind of focused on, okay, so recently we had a lot of changes come through from the US government in terms of how pharmacies are going to be reimbursed, or no, sorry. Well, yeah, no, it affects pharmacies, it affects clinical practices, it affects pharmaceutical manufacturers. And so when we were starting to kind of make this progress towards the middle market and trying to understand the nuances, kind of all these like federal regulations came down, and it's kind of changed our focus again, right? Because now we're very focused on very much on top line revenue again. Um, to where and then really kind of trying to use some of those middle market vendors for some of those more nuanced cases. Um, you know, where some larger organizations might go, they might try to start building it in house. I saw today where what was it, Klarna, which is a Swedish company. They said they were getting rid of their Salesforce uh, staff, right? Or the process. Um, you know, CRM is very much in the way of how healthcare companies manage their providers and their patients, or at least information on the providers and the patients.
Mm.
There's customer service, there's surveys, there's outreach. It has all those. Healthcare has all those things, whether they use Salesforce or not. It depends. Um, but if you have a large enough organization to where you can start building these tools yourself, um, yeah, we might see that more and more, where maybe they don't want to rely on the big box vendors, and they feel that they have what they need to kind of start building it in house.
That brings me closing questions, but yeah, this is something I wanted to discuss and raise it as well. This federated approach, right? We have been working on centralized approach for decades, right? We know data warehouse, enterprise data warehouse, enterprise lake houses, and then this term came as federated lake houses and federated warehouses, right? I was also not a fan of it because my team's supposed to get divided, but end of the day, we realized yes, we need a federated approach because every department, every LOB, they have a money now. Last
Mm-hmm.
time IT was a luxury. Now IT is a necessity, right?
Mm-hmm.
Last time you could depend on one department sitting there creating dashboard and reports for you. And if they don't, you don't care. You do it yourself. But now data is so much, everyone is so much dependent. So they don't only care, they build in-house. When I say in-house, in department, in LOB, whatever you call it, right? But then that brings another challenge of governance,
Mm-hmm.
right? Governance was always a piece nobody cares, right? Just like HR department, nobody cares. Nobody used to care about governance, right? They say, what the hell is why to spend money on governance? But still, this federated approach has come, right? That as you mentioned, dark data, right? Last time, operational systems were sitting in silos, in dark, right? You do not know whether data is there or not. But now challenge is your analytical systems are sitting into silos because every department, every LOB build their own team and they say, okay, we do it ourselves. The moment they start doing it, they do not know what regulatory bodies want. The governance team sitting at one place, they could handle one IT team. Now that governance team has to make sure all these small buckets follow the same governance, right? So in
Right.
federated approach, right, I feel there has to be federated governance as well. Now
Hmm.
every lake house, every federated lake house or XYZ, whatever data store we call it, they need to have their own small governance team who should be referring to the main governance, and that will become key. What do you think? What challenges you feel once everybody start doing this? Because you can't make a mistake, right? You miss one thing, there's a life on thread, right?
Right. And in the beginnings of kind of this data science analytics space, they had this idea of like resident data scientists, right?
Yeah.
So where they had uh, hard lines to the business owner,
Mm,
and then dotted lines to the analytics professional of the
mm,
organization, or the
mm,
governance professional of the organization. And so that anytime they say they had to uh, whenever they wanted to do some sort of like throwaway analysis, that was fine, right? But if
mm,
something was reoccurring or had enough visibility, they had to pass it through some level of governance. Now, a lot of organizations kind of go back and forth. I've seen it where people say, no, 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 no. We have to centralize this. We can't rely on the business owners to tell us when something is going wrong, right? Or when something is at risk, because the business owners are working on their niche. They're not focused on governance, right?
mm,
And so then you're relying on the individual user to essentially manage up and manage their boss to be like, no, boss, I can't do this. I need to talk to governance first. And that doesn't always go well either.
mm,
That just creates more meetings. And so I think it's a top-down approach for sure, right?
Hmm.
It's nothing that I know a lot of the times when they're waiting on deliverables, these kind of, resident analysts like to kind of create their own tools. I've heard it called shadow IT. Some are good, some are not, but they have to hold themselves accountable, right? Which doesn't always work. And so I think it has to come with a top-down approach. It's capable of being done because I've done it. But it does take all of those business owners to be included in kind of the buy-in that, like, hey, you're using these resources, XYZ resources, servers, warehouses, lake houses, analytics tools, um, which comes with requirements, and we will help you with it, but we can't give you access to it unless you agree to how these resources need to be used, right?
Absolutely.
And that worked. And 9 times out of 10, they were like, "Sure, I'm just glad to get my data," right?
Yeah.
But it took somebody that was willing to kind of take the burden off of them, because that's not their niche. That's not what they want to focus on, right? They just want service. They don't want to have to do data work.
See, that is why I was saying when you bring this thing to them and you say, hey, you have to follow that, then there has to be a small team who makes sure they follow.
Yeah,
And once they go across the rope, which is implementation, this small team need to make sure they implemented the right way or not. And what things supposed to be done, what has been done. So that
right,
is where I see a lot of data folks are talking about, actually, which is good to hear. They're talking now, data folks talking about governance. Rare, right?
right,
Previously, we used to damn care about governance people. Hey, these are just auditors sitting over there. But now we want that because we know if you do something wrong, audit is coming, compliance is coming,
yeah,
penalties are coming. So people are focusing on that. Okay, I think we had a good ride today.
great.
And David, I learned a lot from you. Thank you
Oh,
so much.
fantastic. Thank
Yeah.
you.
And I think audience will also have a more depth knowledge of data use in health industry because nobody talk about data in health industry. Who talk about data, right? Because
Very few that I know.
very few, right? So I
Yeah,
hope our this podcast can share knowledge about data in healthcare and more people can will come to you or come to me to talk about data in health industry. Thank you so much, David. Anything you want to share in the end of the session?
for me, I just, at the end of the day, I'm probably more of an operational leader than a data leader. And I just, I think it's really important for people out there to be very invested in their health and about their health, and to kind of learn how to take care of themselves. It's its own skill set. And,
Hmm.
we're trying to create the tools to accomplish that.
Yeah. Again, thank you so much, David. We have to keep in touch. And this is the first one. It should not be the last one. Next time, we will talk about more on technology, like in your experience, how you are implementing data lakes or
Mm.
lake houses or vault or whatever you are doing in your industry. Thank you, David. Pleasure to have you and see you next time.
Yes. Thank you very much. Thank you for having me.
Pleasure. Take care.